Hi everybody and welcome to this episode where we have with us the great Dr. Aarti Deendayal from Hyderabad, and myself. I have had this great opportunity in this one life only that I have worked so closely with Aarti Madam, okay, as a part of this entire journey. So Aarti Madam, hi. I think
Hi Jay, thank you so much for
Hi, I
having me
think I
here.
think we are live, and I think you can probably see me,
Yes,
and definitely I can see you. So let me just verify it on YouTube. Is it live or not? Is it live? Is Aarti Madam being seen? दिखा दे एक बारी मेरे को. Oh, wonderful. Are you able to see the internal picture?
yes Jay, I can see you as well, the great Jay Mehta.
Great, fantastic, ma'am. So here we have a large anterior wall adenomyosis. Can the
Right.
PI be switched only to the fibroid? I mean, only to the adenoma, please. So let us switch the PIP for you, ma'am, so that you being a great sonologist yourself. Golu, only PIP picture.
Jay, before we, you demonstrate how you're doing it, I just wanted to ask a few questions
Yes, ma'am.
about,
Just a minute. I'm so
yeah,
sorry, ma'am. Just a
yeah.
minute. Just wanted to know if you can see the ultrasound.
Yes, I can, very much.
Okay, fine. So just wanted to tell you that it is a large anterior fundal adenomyoma.
Right,
Okay.
right,
And it's a large one. And then now we will be taking it further from here.
right.
Yeah.
So, yeah.
Bye.
So Jay, I think this it's important to talk about microwave management of adenomyosis because I
Oops.
think today's woman wants uterine preservation, and I think
Correct.
microwave ablation is that scientific, safe, and sensible choice. So you are demonstrating it, but what is your criteria for choosing microwave ablation? For patients who are the ones
Uh,
eligible.
Yeah, so see, honestly, madam, I have very limited criteria for this. Can you see that the uterus is less than 10 centimeters in size? You can see
Yes,
the uterus here. It is
yes.
less than 10 centimeters in size.
Okay.
Now, whenever you have a uterus which is less than 10 centimeters in size, it is the uterus whom we basically want to go ahead and do a microwave ablation. Okay, cooling please. Yeah, we want to do a microwave ablation because we understand one thing. See, I've had people who have spoken to me stating that we should only use it for percutaneous approaches, the microwave ablation, and we should not try to consider microwave ablation for a laparoscopic guided ablation. I personally do not think so, ma'am. That is only and only acceptable if you are using a singular probe, and it is only acceptable in countries where reimbursement is allowed. For a country like India, you and me both have seen multiple cases of this situation where people genuinely have no money for this treatment, ma'am, isn't it?
Absolutely, absolutely.
And we have to make sure that whatever we are offering to the patient is sort of a completion therapy with a guidance of removing everything. So often people get carried away in a fact that you can easily do this transvaginal probe, and people think that nothing great is there in this situation, but it is exactly the opposite. It is exactly the reverse. We have seen so many occasions where you have stood. So I just wanted to show one more thing, ma'am, before I start. uh Lavkush, can you please show the PIP here? See, madam, this is the most important thing of doing this procedure. Can you see the PIP inside, Golu? Okay, can you see the probe, ma'am? It has
Yep,
come right in
yep,
the center.
yep.
See this?
Yes,
This is on our basic ultrasound machine. Start karo. Okay,
correct.
and when you see this, see, we have started the ablation. It is
Right,
important that you will be able to now see that fire effect of ablation. Can you see that?
correct.
This is the most important thing. Of course, we need to monitor it on a continuous basis. It is far away from the endometrium. I
Right.
can show you the endometrium in the same picture. See, this is
I
the
can see
endometrium
it.
here.
Yeah, yeah,
Yeah.
yeah.
So yeah, I think now this ablation will go on for the next 4 to 7 minutes, and
Right.
probably now you can ask me all your questions, ma'am.
Okay. So you mentioned that the size of the uterus you prefer should be 10 centimeters or less. And what about
Yes.
focal versus diffuse? What if you have a focal adenomyoma? I'm
It's
just starting.
absolutely okay, ma'am, to do it in a diffuse adenomyosis. In fact, the publication which myself and Sanchari have published, the first publication, that is for diffuse adenomyosis. That is not for focal adenomyosis.
Right.
Focal adenomyosis is something which we have started doing after we published that, and it gives phenomenally great outcomes.
Okay. And what is the basic principle behind this microwave energy, Jay? This is a
Same,
very
ma'am.
commonly asked question.
It is a microwave ablation probe, correct? So basically the technology is microwave. So the microwave technology is going to go and dissipate heat. It works on lateral thermal damage.
Okay.
Entire life in gynecology we have spent trying to reduce lateral thermal damage. This is one of those occasions where we are using lateral thermal damage in order to go ahead and ablate all these tissues.
Okay.
Understanding? Once it goes ahead and ablates, it burns the tissue from inside, the heat causes coagulative necrosis. This coagulative necrosis is then going to let out as a coagulum, okay, which will either come out through the peritoneum, through the tract, or it will come out through the endometrium. So now people are often worried that endometrium should not be damaged, and we have done what, more than 150 or 200 microwave ablations in Hyderabad, where we deliberately drill a small hole in the endometrium, okay, and the patient has a discharge through that part of the endometrium. And when the patient has a discharge through that part of the endometrium, basically the coagulum is completely let out from there, isn't it?
Right. So this probe, you have passed it transabdominally and you have passed it into the uterus under ultrasound guidance away from the endometrium. This is the basic principle. So what is the number and depth?
It is away. It is around 0.5 centimeters away from the adenomyosis. You will start to see that now it has been approximately 2.5 minutes. So you will start to see how the thing is getting necrosed. You know, you will start to see the volume reduction on the surface. Can you start seeing these puckering on the serosa?
Yes.
This puckering is an example of volume reduction which is going to happen from inside. You know, we've seen this, no?
Yes.
I think there is around 12 to 13% volume reduction, sometimes 20% volume reduction, which occurs at the time of the procedure itself. And then there is another 30-35% reduction which occurs over the next 3 to 5 months. The beauty is the pain relief, isn't it? I think you have posted so many videos of patients coming and thanking you for this.
Yes. So you are monitoring the endpoint by looking at the ultrasound image and also the tissue shrinkage, which you are seeing over here, puckering.
Correct. Both the things I am monitoring simultaneously, ma'am.
Okay. Jay, what about the most common intraoperative challenge you are facing when you are doing this procedure?
See, the biggest challenge in this entire procedure is not anything to do with this procedure, actually, ma'am. It is to understand and orient everybody regarding this procedure. The staff, the anesthetist, the patient, everybody has to be oriented, madam. The problem is because of a lack of orientation, what typically happens is many a times, because we are not oriented properly, no, we may not understand what we are trying to achieve in the procedure. And when we only don't understand what we are trying to achieve in the procedure, it makes a big problem for everybody, madam. That is the only thing. Once somebody gets oriented, life is superb, ma'am.
Right. But then, Jay, it is not one size fits all. You know, you change the energy settings based on, you know, what you are seeing intra-op, you know, based on the tissue hardness, the adenomyosis, how hard it is. So it is not like one size fits all. And that is what I think makes you different from many others as well.
Yeah, we will never do that, ma'am. We will always be bespoke. That means every patient will get a particular energy setting. Every patient will get a particular setting of usage. Every patient will get a particular time at which we are trying to ablate. All of that. Now see, it has been 4 minutes. Can you start seeing the shrinkage here?
Yes. It's becoming paler.
It's becoming paler. It is proper shrinkage which is happening over this tissue point, ma'am. And we are going to shrink it more. Basically, it is not going to be that, you know, we are going to leave it as it is. Shrinkage is going to be even more here, ma'am. Can you see this whiteness appearing here?
Yes.
This marks an end point for this region. Matlab, no more at that region, you know, something like that.
Right. And then now you'll move to another region, which is adenomyotic after looking at it by ultrasound, and then you'll again repeat the same process. Can you hear me, Jay? It sort of got cut.
I the tract also.
Sorry, I didn't
Sorry,
get
ma'am.
you. It got cut. I said, so now you're going to
No.
the same process again in another area. Again, ultrasound guided, you'll identify.
Yeah, ma'am.
Right. So how much of
Yeah,
approximately, you're seeing this lateral thermal damage once you're inserting the probe into the adenomyotic tissue?
It
Around,
depends on the energy, ma'am. It
right,
depends on the strength of the energy which you have used.
right.
Ablate, please. It depends purely on that, ma'am. How much energy you have used.
Okay. Now, Jay, the advantage of this microwave ablation is, of course, you are preserving the integrity of the uterine serosa, and hence even the tubes
Yeah.
are not affected, and the patient has an opportunity to try naturally, after this procedure. Versus
Correct, ma'am.
myomectomy, where you are, there is an integrity which is lost of the uterine serosa. And
Yes.
also there is a chance of the tubes getting affected. So when do you decide that adenomyomectomy is the choice for a patient and not microwave?
More than 10 centimeter uterus, no, ma'am.
Right.
We would want to do adenomyomectomy for them.
Okay.
Because that more than 10 centimeters is a killer thing, ma'am.
Right. Now, what about post-op, Jay? You mentioned, and even we have had the experience in Hyderabad, the patients who've undergone this procedure have excellent pain relief. Excellent is the word. And you also have the experience that fertility outcomes also are improved, provided the tubes are patent and they don't have any other associated problems. So, what is it that you see in terms of the post-operative complications in these patients? Fever, okay.
Fever is the most common post-operative complication.
But it is usually low grade.
Very low grade fever, ma'am. Like Vismay will give you a beautiful outlay to that. Can Vismay be given the mic? Kya? Oral mic, apna hand mic hai kya? Because he is handling the patient on the 7th day of the situation. Okay. So let Vismay speak to everybody on this. Vismay, mic le.
Hello.
Hi, Vismay.
Hello, ma'am.
Vismay, about post-operative, complications or discomfort the patient may experience. What is normal and what is, a red flag which we should not ignore?
So the normal I won't say complication. I think it's a side effect we are seeing
Correct.
of microwave ablation,
Correct.
where these patients are having chronic, not chronic, actually 7 to 10 days of low grade fever, or they
Right.
feel feverish. The
Right.
temperatures, most of the patients do measure these temperatures at home, but
Okay.
they do say that the temperature is around 9900, or sometimes even going for 101.
Okay.
And it happens around evening time, and so some do have chills and everything, but
Right.
the blood reports are absolutely normal.
Right.
TLC count, CRP, and everything is fine. They
Right.
do have chills.
Vismay, why does this occur? If you can postulate a theory, because our theory has been always that the coagulative necrosis which has occurred and which is getting drained out. Because many girls will always come to us and tell us that, I had discharge for 6 weeks, 4 weeks, 3 weeks, whatever.
Yeah.
And once the discharge is completed, then
Yeah.
the fever just goes away on its own.
But I think it is the discharge is possible for those tissues which are much nearer to the endometrium.
Correct.
I think those which are far at the serosal layer or at the outer myometrium,
Yeah.
they require that acute inflammation to act and work for them. So I think that must be a reason for this occurring. And even these patients do have, some patients are also do complain of severe sometimes back pain, and even low kind of a pelvic pain. I think when such a uterus rests on that back,
Right.
with that acute inflammation, it might be pinching on some nerves.
Right.
Of course, that is happening for only patients where there then some kind of a deep endometriosis excision, where the nerves get exposed, the peritoneum over it.
So I think
and
all these, it's important to note that these side effects you were mentioning are
yeah, yeah.
progressively decreasing over the next 10 days post-op.
Yeah, madam. Yeah, yeah. But the problem is it's very not the predictability rate is quite matlab, how much it will happen, how long it will happen,
Correct.
and what is the intensity. Now that is different for many patients, and it is
Right.
so yeah, it creates a kind of anxiety for the patient because they are also not they are also not
Geared up.
yeah, they don't know what
But
they're
I think this
expecting.
pre-operative counseling is important that
Yeah, yeah,
may happen and that they should
yeah.
not worry.
Yeah, and I think we have started in a few patients. I think we are starting this chimeral fort for anti-inflammation, and it has
Right.
worked. I think
Right.
I have started recently in a week or 15. I think since 15 days, and it has
Right.
worked for I think 5-6 patients.
Yeah, it has
Well,
actually got, I mean,
and
it's basically knocked the fever out
knocked the
completely.
fever out. The patients are not complaining of the fever,
Okay.
and
That's post-op chimeral fort along with painkiller,
yeah, in
along with
painkiller
the
also,
routine course of
I
an
try to,
antibiotic.
yeah, I try to combine it with a serratiopeptidase one, the
Okay.
enzoflams or the combiflam or zerodols or something, not just the old simple painkillers.
Okay.
And it's working. For the back pain, of course, we have to explain to the patient that as
Vismay,
healing
since
will
you are
occur.
speaking, I want to also make people understand about the modified natural cycle protocol which we are using post IVF for this thing,
Adenomyosis.
post ablation patients in whom we are doing modified natural cycles, and because they are on Zoladex, obviously, okay, or some of them are not on Zoladex. And what is going to happen is when we use an MNC protocol, the pregnancy outcomes have been absolutely fabulous after
Yeah.
that, right?
Yeah. But it is just as sir said, it is not recommended for diffuse adenomyosis with where we usually give Zoladex.
Correct.
Only on those, I think 1 or 2 patients where there was a very concentrated acute or a focal adenomyoma, and we have not given the Zoladex.
Correct.
And tubes were open and all other factors were normal. Yeah, the MNC protocol does work in them quite beautifully. We have seen triple line endometriums and even pregnancies in a few patients.
Right.
But yeah, patient selection is important in such
Right.
cases.
I think the most important is patient selection, as Vismay mentioned.
So Jay, you spoke about patient selection, intraoperative. We are seeing what is going on. Post-operative, we know about, what are the common discomforts patient may experience. Now, how long after this ablation can patients actually attempt to try, if they're going in for trying naturally, how long do they wait?
4
That
to
is
6
one
months.
question. So you say 6 months.
4 to 6 months.
And the 4 months post-op, do you give them depot?
No, ma'am. We normally give it post-op, immediate post-op.
So you give them based on how severe it is, either 1 month or 2 months, or do you give the 10.8?
No, we give standardized. So I think Vismay has an argument on this because I have standardized it to 10.8.
Yeah.
Vismay, what is your comment on that? Because according to me, the suppression which a 10.8 gives, okay, is absolutely fabulous. Band karo.
Yes.
I think so.
I agree.
I'm not a big fan of the 3.75, ma'am.
Yes. I think the suppression with the 10.8 is much more profound and they're comfortable for the next 3 months. And after that,
3 months, ma'am. 6 to 7 months sometimes,
Yes, I agree. Because we've seen it, because even we have had this argument of 3.75 versus 10.8, and we've seen a great outcome with the 10.8 post-surgery. So
Correct.
usually if they want to try naturally, they wait for a minimum of 4 months. And if they're going in for an IVF cycle also, then again, it's 4 months later that they undertake the IVF treatment, right?
Yeah. 4 to 6 months is a very good enough window, ma'am. See,
Right.
people have had this worry. Even we didn't know when we started. So we were allowing 1 month, 2 month, whatever, because we ourselves didn't know that time that, how much window should we allow. But now we have seen our uteruses after delivery, after cesarean sections, at as to what typically happens in a situation like this. And, it is pretty crystal clear that it is better to wait for this 4 to 6 months, because even after, let's say, 4 months, Vismay, can you describe the post 6 month or post 4 month finding of an ablated radius? Like, how does that ablated radius look like?
I think there is on an average, from what I've seen, there is around 20-30% reduction in the volume at 3 months. And 6 months, on an average, I've even seen 50% reduction.
Yeah,
in volume.
50% happens sometimes.
And yeah, so there is no doubt about the size reduction in microwave ablation. It's very good. Only part is you have to be very careful of just as you said, minding the endometrium. Endometrium should not be damaged in any way, because the heat does transmit to the endometrium a bit.
That is correct.
That's it. Like for fertility, yeah, we have to be mindful of the endometrium.
I'm not going to be doing any ablation on the posterior wall because there is nothing there. I am not going to be doing any further ablations along the anterior lateral wall on the right side. I may just want to do a very small burst of maybe, yeah, this is a very hard area. You will feel the haptic feedback there. Okay, maybe approximately 1.5 minutes of ablation here, and that is going to actually cause the entire ablation radius to work beautifully well on the uterus. Now beyond this, because of the heat which has been dissipated, necrosis will set in a while, and once the necrosis sets in, then life is going to become much easier for the patient and for the reduction.
Right. Jay, I would like to also comment on what Vismay had seen post-op 3 to 4 months, 15 to 20% reduction in volume is seen. In some patients with more severe form of diffuse adenomyosis, we also see a little, anechoic gap in the myometrium, and that is why maybe it makes sense to wait for 4 to 6 months, because we've also seen
Yes, ma'am.
these little gaps also resolve over 6 months most.
Yeah. I think Sanchari can comment on that. Can we have the mic given to Sanchari for this? I think Sanchari has got the mic.
Hi, ma'am. Hello.
Yeah, Sanchari, I can hear you.
So, like you mentioned, this gap in the myometrium, like around a week back, I was scanning a patient, maybe 6-7.
Can't hear you, Sanchari. No, can't hear you.
No, her voice is not audible.
Maybe because of the mask.
No, the voice is not audible. Wait, No.
Hello.
Yeah, now she's audible.
Yeah. So just around a week back, I think I was scanning a patient who was like maybe 5-6 weeks post microwave ablation, and I could see this clear needle track through the myometrium, which was, and then I called her for a follow up 2-3 weeks later to see how much the track has resolved. So that is something which is a very nice point that you have made, madam. We do see myometrial gaps and all, but we've also seen complete resolution and complete filling of those spaces, maybe 4 months, 3.5 months, latest 5 months post procedure.
So, sorry to cut you guys, but see this, the procedure has been completed. Can you see the absolute shrinkage on the anterior wall there?
Yes.
And almost near complete shrinkage of the posterior wall, but posterior wall has very little adenomyosis. Whatever was there was on the anterior wall. This anterior wall is going to heal absolutely beautifully. Okay. And hopefully after 4 to 6 months, the lady is going to have an opportunity for a natural conception. So there is no question, absolutely no question in that fact that she will end up having a, sort of a natural conception at the end of this procedure. So, Aarti ma'am.
Jay, I have just 2 quick questions which are valid.
Yes.
Yeah. See, you've done anterior wall ablation, right, Jay?
Yes,
so
ma'am.
how, what are the precautions you take so that adhesions don't fall here? Form.
Nothing major, ma'am. Just the correct technique, na?
Right. And also
just the correct technique. That's it.
Okay.
That is going to be like more than enough, ma'am. Just the correct technique for doing it.
Okay, Jay, one more thing patients always worry about is recurrence of this, because we are not completely curing it. This is what we have to bring across to the patient during counseling pre-operatively, that it is not a cure for adenomyosis. It is only decreasing the bulk of adenomyosis, and there is going to be a good pain relief and better fertility outcomes. But in your subsequent scans, even after the surgery, the report is going to continue to show adenomyosis. So it's not like it's going to disappear. And post-operative recurrence is what they asked, often ask you and me.
Yeah.
So what is your comment on this?
No,
we follow the patient for 2 years and we rarely see again, again an increase in size, but you always tell the patient if it increases, it may increase in a small number of patients post 1 year or so, if at all.
True. That we have to tell everyone, ma'am, that a small increase may occur, something may change, but what we have seen is otherwise, the re-intervention rates are very, very minimal. There is nothing called recurrence here.
Correct.
What we are trying to tell the patient is maybe about a re-intervention rate, ma'am, and not a recurrence rate,
Correct. Jay, and see, this case you have shown is a very clean pelvis, but most of the times you're not going to encounter such a clean pelvis with adenomyosis.
Not at all.
Most of our patients have associated severe posterior wall adenomyosis with, multi-compartment endometriosis. Those are the type of things you very often do.
Yeah, that is the most common thing. So the core principle of this surgery is to make sure basically that at the end of this, okay, you are doing adhesiolysis first, and only after adhesiolysis you are going ahead and doing anything else for the patient, ma'am.
Correct. And the last question before we end this session, Jay, people definitely want to know, see, this is an advanced surgery. It requires advanced technology, expertise. There is a probe used for every patient. So why is this procedure expensive? Both doctors and patients.
Madam, probe is only 1.5 lakhs.
Exactly.
See, every patient is going to be given an option to use a fresh probe only, right? We are not living in that time that we cut down on cost of all these things because we think that the patient has no finances. Everybody has the finances to do it, ma'am. Everybody has it. It is just that we cut down on the finances thinking that the patient does not have it, which is absolutely incorrect on our part, So that is what makes the procedure expensive. Otherwise, if you see, ma'am, it's not such an expensive thing for the patient, ma'am.
Right. Yeah, I think it's a combination of using the best technology, singular, probe, and the expertise.
All three, ma'am. All three will work together, ma'am.
Work together, because of which this procedure is more expensive. But then, as you rightly said, it's okay to put in that sort of a expenditure for a pain relief. Otherwise, the quality of the life of the patient is very badly affected. I think we have seen all age groups of women have this condition. We have seen youngest 17, 18-year-old have this condition, and we've seen even 45, 48-year-olds have this condition. When we operate. So thanks, Jay. This was a superb.
Thank you, Aarti ma'am, for taking out time. Thank you. Bye.